guys, my name is Lynn Gollenbeck. I'm the orthopedic nursing team leader. We're here today to do a pre-op shoulder class. So today we're going to have, we don't have everybody to come to shoulder class, and I'll explain a little bit why. Physical or occupational therapy, I think actually Kim from OT is going to come and talk a little bit about the exercises that you're going to do after shoulder surgery. Somebody from discharge planning will come down and talk a little bit about going home and what they need to do to help you out with it. Andy from respiratory will come. He's going to talk about the use of an incentive spirometer and the importance of coughing and deep breathing after. Subacute rehab doesn't come because shoulders go home. They don't go to subacute rehab. Every so often we do have someone that needs to go to rehab, but that is that's more the exception to the rule. At this point in time, your doctor probably has even told you if he feels like you're going to need to go to rehab. He probably already talked to you about that. Every so often we do have somebody that has a total shoulder that goes to rehab, but more than likely they do go home. We do not
Can I ask you a question? I'm sorry.
Sure.
Am I allowed yet?
You can ask away.
The other packet they gave us said you'll be in the hospital 1 to 2 days.
Mm-hmm.
Now, does the day you have surgery, does that count as 1 day?
No, overnight, one night.
Overnight.
It's usually one night for
Okay.
shoulder.
All right.
Yeah, maybe a second. Home care, we don't send a therapy into your home in the beginning either. And here, there's a couple reasons why. There's only like 2 or 3 exercises that you initially do after shoulder surgery. Until you follow up with the doctor, those are the only things you're going to do. So it's kind of a wasteful for you to utilize any home care visits that you may have, and to have to pay any copay that you have for home care for exercises that you really can't do. So
I'm sorry, I'm going to bug you.
you ask.
I have a physical therapist that I go to already. I can still use him.
Oh yeah, but it probably won't be initially right after surgery.
Like how long?
Well, usually when you follow up with the doctor, that's when they progress you to outpatient therapy. It's right where I was.
Pardon?
It's right where I was before you asked that question.
I'm sorry. I'll try. I just talk a lot. I'm sorry.
You know what? I love people that ask questions. This is what we want. Because people are thinking it, or not, and then they're like, oh, wow, I didn't even think of that. So, no, ask away. Okay. So home care, we don't really do for shoulders either. So, inside your packet, there is some information for Meals on Wheels. Some people need just a little bit of help when you go home, so we put that in there. There is a healthcare proxy form. We encourage every patient that's admitted to the hospital to come in with a healthcare proxy. If you have one at home, bring it in. If you don't, take that home and fill it out. Consider who you'd want to list as your proxy. One thing to know, though, is your signature has to be witnessed by 2 people. And a lot of people don't have those 2 extra adults around at home. You can't have your 5-year-old grandchild sign it for you. So bring it in unsigned the morning of your surgery. And then 2 people here in 160 will witness your signature. The list of rehabs we don't put in there, kind of just like I talked about. You probably don't need it. Again, if the doctor has told you that you're probably going to need to go to rehab, we'll talk a little bit after class and I'll give you that list individually, okay? There's a little survey if you don't mind taking a second to fill it out. On page 6 of the booklet, there's some information for visiting hours, telephone, TV, cafeteria. We're really kind of lax with all of that. Visiting hours are posted 10 in the morning till 9 at night. We don't want to limit your family from coming to see you if you want your family to be here. It's honestly, most people's comfort level is with their family, so if that's what you want, somebody to be here with you, that's absolutely fine.
I like to be left alone.
Okay. We can change the rules for you. But we even accommodate if someone wants to stay overnight. One of the chairs in the room folds out to a twin-size bed that if someone wants to stay overnight, they're more than welcome to. Again, we want you to be comfortable. We do encourage family, though, to come, especially for therapy, for physical therapy, so that they can see what exercises the therapist is showing you how to do, and then they'll be able to help you out at home with it. Oh, you know, good job, you're doing that great, or aren't you sure? Are you sure? Didn't she say you should do it this way? So we'd like for you to have somebody here. There is no charge for telephone or TV services. Most people bring their cell phone. That's absolutely fine. There's a full-service cafeteria on the 2nd floor. There's about 6 or 8 different stations, all different kinds of food. And then on the ground floor, there is Subway and Tim Hortons and Mighty Taco. Before surgery or pre-op testing, if it hasn't happened, it might be happening today. But your pre-op testing is going to be done here too. And that's done in 160, and that's also where you come to the morning of your surgery. There is a list of medications that you need to discontinue prior to surgery. They include, but they're not limited to, any aspirin or aspirin products. So the biggest one that most people see here is an 81 milligram aspirin. A lot of us take that every day. That has to be stopped a week before surgery. Any NSAIDs, any non-steroidal anti-inflammatories, Advil, ibuprofen, Motrin, Aleve, if that's something you're using for pain, that has to be discontinued before surgery also. Fish oils, over-the-counter multivitamins, and if anyone's on a Coumadin, a blood thinner, Coumadin, Plavix, Eliquis, anything like that, that has to be discontinued a week before surgery too. Those medications that the doctor wants you to restart, will restart the day of surgery or the day after surgery. Any of those discontinued ones. If you're going to be going home, you want to make sure that you have someone that's going to be available to help you out at home. Kim, when she comes from Occupational Therapy, she'll show you the sling that the doctor uses and show you how to put it on, and we'll show your family how to help you out with putting it on and taking it off also. We also kind of encourage you that if you're, especially if it's your dominant arm, if you're going to have your right arm done, maybe for a time that you're home, take that arm and put it under your shirt for a couple hours and see what life is like. You're not going to really know what you're not going to be able to do until you're in that sling. So try to kind of practice it. So it could be as little as the toothpaste cap is on too tight. It might be that you have to, especially again if it's your dominant arm, toileting might be a little bit different. So the things that you have to try and make sure that you know how to do to help yourself after surgery when you're not going to have the ability to use that arm. It might be that something up in the cupboard is up too high. Thank you, Janet, something that you have to reach up for or whatever. But give yourself a couple hours of having that shirt or your arm underneath the shirt and kind of practice what it's going to be like. And again, making sure that you have somebody around that's going to be able to help you out. You want to try to eat as healthy as possible after surgery. Appropriate amounts of fruits and vegetables, proteins, grains. Get an adequate supply of iron from red meats, fortified cereals, green leafy vegetables. The potential for blood loss is there after surgery, and we just want to make sure that we're rebuilding those red blood cells, getting your iron level back up. You want to bring this booklet to the hospital with you. You also want to bring some comfortable walking shoes, something that's safe. Sneakers are honestly the best thing to wear. Please don't wear anything you step into, don't wear flip-flops, anything like that. You want to have the stability while you're walking. You want to bring a brush or a comb, glasses if you wear them, dentures and supplies, and hearing aids. CPAP or a BiPAP, if you use one, bring that with you if you'd like to. If you use one and you don't want to bring it with you, that's fine. Our respiratory department can hook you up with one. A lot of people say, though, that the mask that we use is kind of cumbersome. So they would much rather have their own that was fitted for them. So if you do want to bring that with you, that's fine. Please do not bring any of your home medications. We're going to give you everything the doctor wants you to continue taking when you're here. So you won't be bringing anything from home. We do provide toothbrush, toothpaste, shampoo, soap. It's not necessary to bring anything with you here unless there's something special that you like to use. The morning of your surgery, you're going to take whatever medications you've been instructed to take with just a small sip of water. You're not going to take any diabetic medications. If anybody is a diabetic here, you're not going to take any of your diabetic medications the morning of your surgery. When you have your pre-ops done and when you follow up with your primary physician for medical clearance, and they go over your list of home medications, they're going to let you know what you need to take and when what you need to stop and when. Diabetic medications, depending on how you take them, at least that morning you're not going to take it, and it could be the night before. Again, your doctor's going to specify all that for you. We are going to check your finger stick, though, 4 times a day when you're here. And a lot of diabetics don't do that themselves, especially non-insulin dependent. But we will be checking your finger stick 4 times a day, before each meal and at nighttime. You bring your picture ID, your insurance card, and any copay that's due for your inpatient stay when you come to 160 the day of your surgery. You're not going to need anything to eat or drink after midnight the day before surgery, the night before. You're going to get 2 different times from your physician's office, your time of arrival and your time of surgery. It's usually a couple hours in between. This way they get you back in the back, they get you prepared. They usually let your family come back in with you. You meet your surgical nurse, the anesthesiologist. He's going to ask you if they've ever had trouble with anesthesia before. And then you're going to meet your surgeon. He's going to confirm what he's doing, left shoulder, right shoulder. He's going to take a Sharpie and label it. He's also going to be the guy that's going to let your family know how long surgery is going to be. A shoulder is usually a couple hours. He's going to let your family know he's got a time that's actually slotted for you. We just ask that your family be back in the waiting room to talk to the doctor after surgery. He will talk to you. We do our best to try to pre-assign room numbers, so if you do know what room number you're going to be coming to up here, family's welcome to come up to the room. If not, if it's one of the busier days and we have to wait for discharges to happen, we've actually started utilizing this room for family's benefit, to kind of get you out of the waiting room downstairs, get you up here closer to the floor. We supply the coffee and pop and snacks and all of that too. Again, that's day-to-day specific depending on what's going on that day. But once you're ready to be released from the recovery room, your nurse down there will call up here and give a report to the nurse that's going to be taking care of you. One quick thing I like to talk about is the dental prophylactics. You will need to be pre-medicated before you go to the dentist with an antibiotic, and that's to help prevent infection. So right now you go to the dentist, you have your teeth cleaned, you might have a little redness on your gum, and you wake up tomorrow and it's gone. Now you got this new joint that potentially can get any infection that would enter into your body. The bacteria that we have in our mouth can settle into that new joint. Of course, we don't want that to happen. So the pre-medication for the dentist, it's normally amoxicillin unless you have an allergy. You take it 1 hour before any dental procedure, even a routine cleaning. It's a prescription you get from your dentist office. And depending on your physician, it might be for a lifetime that you have to do that for. Newer studies show now that just up to 2 years is sufficient, and then your body's gotten used to that new joint. So it's really going to be dependent on your doctor. But one thing they have asked me to say is that they do not want you to have any routine dental work done between now and surgery date, and up to 6 months after surgery. So your best bet is before you go to the dentist the next time, talk to your surgeon's office and get their approval. If you have anything emergent between now and surgery date, by all means, just give them a call and let them know. So you have your surgery done. Tomorrow you wake up, you got your new joint, you got this new shoulder. Therapy is going to come and get you, take you down to the therapy gym. There's an aide named Melina. She's going to bring you down to the therapy gym first thing the next morning. We do work a little bit around your pain medication, so if you know you're due for something soon and you can't do it because of your pain, we want to set you up to succeed.
Can I ask a question?
Surely.
Can someone else ask one too? But I have been on a lot of medications for my back. I just have to say, got Dr. Gosie's office, and that'll tell you, okay? And none of them ever touched me. And they ended up saying the neurotransmitters in my brain don't respond to it. So what will they do?
Each person's pain is handled individually. We do have a standard order set, but then some people just don't fit into that standard order set, which sounds like maybe that's what will be with you. And then we have to do something a little bit different for you. So,
do I have to tell somebody?
Yes, you definitely want anesthesia when you talk to them. Let them know that you do, and then also the doctor. For all of you guys, when you do have on the day of surgery, when they take you in the back, you're going to have a little kind of a brief history with either your physician, either the surgeon, or most likely either one of his residents or extenders, like the physician assistant, the PA. Someone's going to come in and talk to you guys. That's the guy. If you have any kind of issues at all, you want to make sure that you just let them know that. They ask the question, so it's nothing you really have to think about. Do you have trouble with pain? Have you taken anything for pain that works or doesn't work for you? They'll ask those questions, but that's who you just want to make sure that you let them know. Okay? Very good question. And please don't hesitate to ask questions. You can. It's okay. Your call light. You're going to have your call light available to use anytime. We do purposeful round, and I'll talk a little bit about that. But your call light, you're going to have to use. We want you to use that. That alarm. We do put all of our post-op patients, we engage the bed alarm. And what that does is it kind of alerts us to someone trying to get out of bed by themselves. We want to help you. You have anesthesia in your system. You're still unfamiliar with the pain that you're having in this new joint. And even though your legs are good and they're working, we still want to be there to help you out. So we do engage the bed alarm, which alerts the staff that someone's trying to get out of bed by themselves, and then we kind of hustle in to help you out. Daily labs, blood tests, we're going to draw every day. We are going to make sure that all your levels are where they need to be. Blood transfusion. Every so often someone needs to have a blood transfusion. It doesn't happen that often, but it does happen. If it does, a sample of your own blood is sent down to our blood bank. It's run through hundreds of tests for compatibility. A unit of blood is sent up to the floor and administered bedside by the nurse taking care of you that day. We check your vital signs every 4 hours, including your pulse oximetry. We want to make sure your oxygenation within your body is okay. Foley catheters, we don't see too much, and for shoulders, hardly ever. But hemovac is something that we do see sometimes. Hemovac is a drain that's placed during surgery into the joint space, and what it does is collects extra blood and body fluid from around that joint space to help prevent swelling. If you do wake up with hemovac in, it will be removed the next morning by the physician. Your output it's drained and monitored by the nurse taking care of you each shift, and the doctors do track how much output there's been. The catheter tip that's actually into your skin is very small. It's just closed with a Band-Aid when they take that off the next day. But we do see this more so with shoulders than anything else. TED stockings you probably will wake up with to help prevent blood clots. So these are compression stockings that they'll put on you during surgery or just before surgery. And you will have these on, probably a standing order when you go home with these TED stockings too. Foot pumps or leg pumps, these hook to a machine that's air in here to promote circulation. And again, that's to help prevent blood clots. The Aquacell dressing that the doctors use is waterproof. So this is, you can take a shower. This is kind of a big one, so don't get nervous. But it is a waterproof dressing that the doctors use. So you are able to shower. You will go home with that Aquacell dressing on, and then on your discharge there'll be your standing order as to when it's removed. We'll give you some type of a anticoagulant or a blood thinner, and unless you have history of clots, it's normally a high-dose aspirin, 325. Yeah.
What if you're on a pain med for multiple injuries? And, I take it for my shoulder, I take it for my back, I take it for my neck, and I also have another shoulder that's shot.
Uh-huh.
I mean, when you come here and they put you on their medicine, start to back you off to see how the shoulder's doing. What about your other pain?
Well, usually what we do in that case, again, everybody's pain is individualized, even though we have our standard order set. So normally what we have to do is kind of give you what you've been already used to taking, and then we got to add a little bit more to it. But again, it depends on the doctor.
I figured that's the way it would go. Okay.
Yes. We're going to give you an anticoagulant. Like I said, it's usually a high-dose aspirin unless you've had a history of a blood clot before or you have atrial fib that you use a blood thinner. Colace or another stool softener. Pain medication and immobility slows the motility of the bowels down. We don't want you to get constipated. So we'll give you some type of a colace or a stool softener.
I was talking to a friend who had this done with Dr. DeQuinn 2 years ago, and she said, I don't need the stool softener. And she told me, take the stool softener.
Oh, absolutely. Absolutely, you're right.
It was a mistake on her part not having
Yes,
the stool softener.
and you know what the thing is, it's not like people, because you're not feeling constipated, but we still want you to take that stool softener. It's not really going to be necessary to have a bowel movement before you leave as long as you're not feeling constipated. So that being said, we're going to listen to your bowels. We're going to make sure that you're passing gas, but we're also going to encourage you to take that stool softener just for that reason, okay? Because that can happen. Then all of a sudden you're backed up. Pain medication, of course, we're going to be giving you. We do purposeful rounding the hours from 6 in the morning till 10 at night. Someone from the staff is in to see you. We want to first see your needs. How's your pain? Are you comfortable in the position you're in? Do you have to get up and go to the bathroom? And do you have everything you need within reach? Usually it's your cell phone charged or plugged in behind you, and you got to get your phone charged up. You always have your call light though. During night shift, it's every 2 hours, but just make sure you have a good conversation with your night nurse. If you've been taking your pain medication pretty regularly during the day, don't sleep through pain medication. And that can happen sometimes, and then you wake up and it's an hour late, and then it's trying to catch it, so we don't want that to happen. So if you've been pretty much using it regularly, I mean, some people do very, very well because they use a block, and a lot of people don't even have any pain because they're using a block. We'll explain all that to you too, about the nerve block, but I don't want to scare anybody with pain, but we want to just do what we need to do to stay on top of it, okay? We do have a program available, it's called Meds to Beds, where we are working in conjunction with Medcare Pharmacy downstairs on the ground floor. And this is the ability for you guys to choose if you would like what prescriptions you're going to go home with from here, usually pain medication, maybe a stool softener, something like that. What you're going to go home with, you have the ability to have that prescription sent downstairs to our pharmacist. One of their techs from Medcare will bring it up to your room, deliver it right to you, collect whatever copay you have due for prescriptions, your regular copay. Or if you don't, that's even better. But it's what it does, it saves you the step of having to stop at your Walgreens or CVS or wherever on the way home to pick up your prescription. So that is something available. Our discharge planner or social worker will talk to you a little bit about it, but just know it's there. If you're interested in doing this, you can ask that question from them. There is no parking fee for today at all. You're going to get a few different business cards from people who are coming in. We just want you to make sure that you utilize whatever you need to as far as cards go. Whatever questions you have when you go home. Because you're probably going to think of something. You think, oh, I should have asked her. Wow, did she talk about this? Call me. You can always ask. On the front of your folders is either my card or Renee, my unit manager. Please don't hesitate to use those, okay? Any questions at all? I'm not going anywhere, so if you do have any questions, you can ask away.
Is there a timetable to have clearance by your family physician?
I think that all that has to be done like within 2 weeks before surgery.
We'll be told when that's to be done.
Yes, you're gonna have your labs done, so is Dr. DeQuinn your doctor? So Paula will send you
info
when you have to get your labs done. Your pre-op, come here and you do your labs, your EKG and your blood work, and then usually a few days after that you see your primary physician, and that's normally done within that last couple weeks before surgery.
Okay. My pre-op's here today. My operation's the 1st. I see my family physician the 25th.
Yeah, that's fine. That's fine.
Do we call the family physician?
Yes, to set up a medical clearance. And you just let them know when your surgery date is and when your pre-ops are, and that's not going to be anything new to them. They'll understand what a medical clearance is.
Okay,
and
I
when
don't
they
have pre-op time yet.
Okay, so as soon as you get that, then you can let them know, and then they can set that up.
Okay.
You said Paula sets up the tests?
Yes, the date for your test, yes.
After my primary?
And no, your tests are first, because if you think about it.
I'm seeing my primary at the end of the month, but I haven't got any scheduled for any tests.
Give Paula a buzz.
I did.
Okay, leave her another message.
She said she'd get back to me. She knew the date.
Yeah, leave her another message, just because if you're seeing them at the end of the month, I mean, it's still 2 more weeks. But what you want to do is your blood work, EKG, chest x-ray, your physician needs to have in hand in order to do that medical clearance, because they need to see those results from your labs that you have done.
I have a standing appointment right now with my doctor for this week,
Okay.
Thursday.
Mm-hmm.
And I'm having my blood test tomorrow.
Okay.
Is that okay?
Yeah, they'll have it. Everything's so electronic now.
Okay.
Everything is so electronic. It used to be where, I mean, seriously, years ago I worked for a doctor, and it used to be like we had to wait for the mail. I mean, that long ago. And then it was at least it got faxed. But now it's all electronic. All they do is go into a link and pull up your.
So it's okay to go ahead and do it?
Absolutely.
This had nothing to do with the surgery, just so happens that.
Yeah, and then, but you want to make sure you let your doctor's office know, though, it's going to be medical clearance, because they may need a little bit more time for you.
Okay.
They need to know it's medical clearance. Okay?
Yes, thank you.
All right. Any other questions? Okay, a lot of good questions. Thank you. All right. Hi. How are you?
I'm good.
And your sign too.
Hi, I'm Kim. I'm from Occupational Therapy. So I'm actually representing both physical therapy and occupational therapy today. So your surgeon will be ordering both physical and occupational therapy for you post-op. So the day after your surgery, we come either down to your room or we bring you down to our therapy gym. And what we do is we review with you how you're going to get dressed and bathed. And we're just really going to basically make sure functionally you're able to walk around and address any barriers you might have to get into your house, stairs, just for safety. You don't think about, but once you take one of your arms away and you have it in an immobilizer, it does tend to affect your balance. So we just want to make sure you're safe before you go home. From an OT standpoint, so I'm going to address with you how you're going to get dressed, bathed. As far as clothing types, things that you might want to think about, things to bring to the hospital with you. Big baggy shirts are usually easiest to wear, okay? And you are going to dress like you normally would. So you actually are going to put the sleeve onto your arm just like you normally would, today. You're not going to drape it over. A lot of times people think they're just going to drape it over. The sling that you're going to go home with does get worn on the outside of your clothing. So big baggy shirts, usually something that closes in the front. If you don't have anything like that, a t-shirt, big baggy t-shirt is fine. Pants with an elastic waist do tend to be easiest for you to get up. So those are things that you might want to think about packing in your bag for the hospital. Depending on who the surgeon is, does everyone have Dr. DeQuinn?
Yes.
Yes. Well, Dr. DeQuinn? Okay. So Dr. DeQuinn uses this sling here, which is called a deluxe sling and swath. So you will wear this post-operatively, okay? And you're going to wear it until Dr. DeQuinn tells you you no longer need to wear it. You wear it at night when you're sleeping and during the day when you're out in public. If you're sitting in a chair watching TV, you are allowed to have your arm out of the sling resting on a pillow in front of you. But if you're going to get up and move, he does want it on. So we do show you how to put this on. Yes?
Do we sleep in bed or on a recliner?
You can sleep in bed. So as far as positioning in bed, if you're going to be laying on your back, you're going to have your sling on, and you can always put a pillow or rolled blanket if you're on your back underneath your arm, just so your arm doesn't have that tendency to want to fall back. But yeah, normal bed is fine. If you prefer, to sleep in a recliner, as long as. Yeah, but I mean, ideally, there's no reason why you couldn't sleep in your bed.
Okay.
And again, we do address making sure bed mobility, you're able to get yourself out of bed. We show you different techniques if there's things that you're having difficulties with. We will help you so that you can be as independent as you can when you go home. As far as the sling goes, I'll just kind of quickly demonstrate. So we do show you how to get these on by yourself if you have no one at home to help you.
Do you want to do that?
What? Show them how to get it on? I can do it.
You can.
Yeah. So the idea of the sling is you wear it like a pair of suspenders. So the straps are going to go one over each shoulder. They're going to crisscross at your back. So what you're going to do is you're always going to start with your operated side. You're going to take this. It's going to wrap behind you. And it's going to attach in the front, right by your wrist. And this one's just slightly big for me. This strap, we loop it over our head, push behind, and come underneath by our elbow to attach for support. And then this will wrap around. And again, we go through this with you. It's kind of funny the day you wake up and we throw all this information at you. No one really tends to understand it. So we do come back to your room if for some reason, you're having difficulty doing it, or if maybe your family members aren't in yet. We do come back to the room and review it with you and review it with them.
Can you turn around? You gotta go to work like that?
Oh yeah.
It
But
works.
the nice thing is this gets worn on the outside of your clothing, so you don't have to worry about this chafing your
Ma'am,
skin.
it works. Take my word for it, it works.
This
Doesn't look nice though.
Yes, I'm a veteran, I can tell you. It works. And I wouldn't want to tell you how many times. I don't want to embarrass anybody.
Yes, so this is what you would be going
It
home
works.
with
Take my word
post-operatively.
for
Okay? So we'll make sure it fits you okay, and again, we'll review all of that with you. PT is also going to focus on the exercises that you're going to be doing post-operatively. After your surgery, there's no active movement at your shoulder, meaning we don't want you lifting your arm up at all. But a passive movement is okay, and if you did go to therapy before, you probably have done pendulums, which is what we will be doing with you post-operatively. So basically the arm is just hanging, so you're leaning onto a steady surface. This is not quite steady, so I'll use the table. So you're just hanging onto a steady surface, and what you want to do is you're actually going to move your hips, kind of like you're dancing. So So really your arm is just more or less going along for the ride, okay? So I'm not lifting my arm up at all, the momentum of my body is moving my arm. So there's a few directions that you're gonna do, and I believe in the booklets, let me just see what pages they are on. So if you look on page 19 in your booklets, this does talk about the pendulum exercises. We do want you moving your elbow, your wrist, and your hand. So again, we make sure that you are able to do all of these exercises before you leave. Okay, and this is all you're gonna be doing until you at least follow up with Dr. DeQuinn. Yes?
I see a physical therapist 3 times a week, okay? Now, would I heal faster doing physical therapy,
Outpatient, you're not gonna start outpatient right away. That's something you would wanna discuss with him, but more than likely he'll tell you that you're gonna wanna wait at least until your first follow-up visit post-operatively, and at that point he'll determine when is a good time for you to start outpatient therapy. But from now until you follow up with him, all you're doing is these pendulum exercises. And really there's no reason why there's nothing the therapist is gonna do with you that you can't accomplish on your own. You're better off saving your visits, because you probably
but I
are
work
limited.
out with them too. And I can do lower body.
You could. I would just be careful, because obviously you don't want to do anything where you're going to chance losing your balance and falling, because
Right.
that would be a concern.
Yeah.
And you don't want to do anything to push your shoulder at this point. I mean, I would recommend at this time just waiting until you follow up with Dr. Quinn and then discuss that with him. Okay? All right. Any other questions as far as clothing type or what to expect? Okay. Well, good luck. We'll see you all soon.
I do, clothing. You have to have clothes that you can pull up with one hand, right?
That's why the pants with the elastic waist
Okay,
tend to be
Pajama bottoms.
That works, yeah. Pajama bottoms, yoga pants, sweatpants, anything that's kind of loose and easier to pull up.
Okay.
Yeah, and again, we do kind of help you problem solve through that, and we actually do work on getting clothes on you
Okay.
while you're here, so that you kind of know what to expect.
Okay.
Okay. All right, and it doesn't hurt to practice now too. Practice one-handed, not moving that shoulder.
And
Yes.
Do you use the sling, is that provided with your discharge?
Oh, you come out of the operating room with the sling on. Yep. So you'll actually come up to the floor, and you'll have this on your arm already. Okay. All right. Any other questions? No? Okay. Well, good luck, everyone.
Thank you.
Thanks, Kim.
Everyone, my name is Andy Mulp. I'm from Respiratory Therapy. I'll take a few minutes to talk to you about this breathing device here we're going to have you use after your surgery. This is called an incentive spirometer. It's basically what it is, it's a visual aid for you to see how much air you can pull into your lungs, okay? It's a way for us to encourage you to take nice deep breaths, keeping your lungs nice and open, keeping them healthy, okay? So anytime anybody has surgery, especially joint surgery where you're laying in bed for extended periods of time, you tend not to take deep breaths as you're laying in bed. So as that happens, your lungs actually collapse from the bottom up because you're not taking nice deep breaths, you're not moving around. That's a source for infection, that's a source for oxygen problems, multiple reasons to keep you in the hospital longer than you need to be here, okay? So this is a very simple way that we can prevent that from happening, all right? So what you're gonna do is through this mouthpiece right here, nice tight lip seal, you take a slow deep breath in just like you're sucking on a straw. And when you do that, you see this blue indicator move up and show you how much air you're pulling into your lungs, right? You want to pull that thing all the way to the top of your breath as high as you possibly can. Hold it for a couple seconds and then release, okay? So as you're doing that, you're expanding your lungs as big as possible. You're reopening any areas that may have collapsed down. You might do some coughing when you do that, which is a good thing. If not, we ask that you do a little forced coughing, again, to mobilize anything that's down in your lungs, keeping them as healthy as possible, okay? Everyone's going to be different. Some people are going to do 1,000, some people will do 3,000. It depends on your age and your sex and your lung history. Are you a smoker? Were you a smoker? Do you have COPD? Do you have asthma? Those kinds of things, okay, here. So the goal really is to do the best that you can do. Get that as high as you possibly can with that big, deep breath in, all right? So what will happen is you'll get upstairs from your procedure. We'll bring one in for you pretty quickly after that. We're going to go over it again. We're going to have you do some practice runs. From that point forward, we want you to do it on your own, all right? Every 1 to 2 hours while you're awake, about 10 breaths, nice, slow, deep breaths, do a little bit of coughing. We're going to come in, we're going to encourage you to make sure you're doing it as well, all right? Really, the first 24 to 48 hours is the most critical. After your procedure, you want to reopen those lungs, get them nice and open. As you're doing physical therapy and you're moving around a little bit, you don't have to use it quite so much. But that first 2 days, every 1 to 2 hours, I would pick it up and do 10 breaths, okay? Just to make sure that we're keeping those lungs as healthy as possible. Questions for me? Okay, thank you.
Hello, good morning, or good afternoon. My name is Elizabeth Reedy. I'm a hospital social worker. I'm gonna go over a little bit about the kind of social work discharge planning role and then open it up to questions if you have them. So it's myself and then Alyssa, she's our discharge planner. She or I will see you right after surgery. We'll do like a quick assessment, make sure you have support, somewhere to, was that a question or?
No.
Oh, okay, just a wave, hi. And then we'll get to know you, kind of figure out a plan to get you home safely or to get you to rehab safely. Those are kind of the two discharge options, so we can discharge you home or we can discharge you to rehab. Most shoulder patients do go home as long as you have someone available that can help you. It's going to be a little tricky to get dressed with an arm in a sling, so it's always a good idea to kind of have like a point person or caregiver at home. If you don't have one, we can make referrals to rehabs, and then you would stay at rehab temporarily until you're strong enough and independent enough to go home. Typically, shoulder patients don't go home with home therapy. The physician would prefer you either go home with family assistance or you go to a rehab facility. Those are kind of the two discharge options. Is anyone thinking about going to rehab? Are there specific questions about rehab?
I'm thinking.
Thinking about it? Okay. What we do recommend, even if you're thinking about going home, we do recommend you look in the packets. Are there?
I'll get it.
Okay. There will be a rehab list that you can look over. What we recommend is take a look at the list. If there's a facility that you're interested in, give them a call, and you can kind of reserve a room there. We equate it to like making a hotel reservation, but they don't charge you. And then if you get here and we find out you don't need rehab, we'll take care of canceling that for you. So it's a good idea to just have a backup plan in place in case you don't get right home. So, are there any questions? That was kind of it in a nutshell. Are there any questions about home, rehab, social work, anything? No? Okay. All right. So I have my card up front. If you want to take one, feel free. Give me a call if you think of anything at home. Okay? All right. Take care.
Thanks, Liz.
Use ice packs.
Okay, guys, that's it. Any questions at all? Yes.
Did we cover anything when they talked about using the sling all that time on bathing or showering or what?
Physical therapy is occupational therapy more so when you go down to the gym. That's okay. They're gonna show you how to do that. They will show you how to shower. And like I said, the dressing is waterproof, so you can take a shower. And it's really just basically like a pendulum exercise, like she was showing you, and that's kind of how you wash. So they will show you how to do that. They'll make sure that you can get bathed and toileted and all of that before we leave here.
How about the sling itself? Is that water?
No. No, so you won't have the sling on in the shower.
Okay.
Okay?
Just sounds a little tricky.
It is, but you know what? What happens is we'll make sure that they'll teach you how to do it, but then also you're gonna have to demonstrate that you know how to do it. Okay? So that's how it'll really work. That demonstration to make sure that it's safe to do that.
And they do that after the surgery, are you saying? It's
Yep.
not before you go home?
Yes. Yes, they do work with therapy. We'll work with every patient 2 times a day.